Welcome, everybody. My name is Beth Stronach. I'm happy to be representing RASopathies Network this morning or today, depending on your time zone. We're delighted to have speakers who are going to speak on feeding issues or feeding problems in RASopathies. At RASopathies Network, our mission is to advance research of the RASopathies by bringing together families, clinicians, and scientists, as we are doing today. Our board of directors consists of parents of children that have RASopathies. Lisa Scheuer is our president. I am the secretary here with my son, Bruce Deckman, our treasurer, and Lee Johnson over here, and Kara Borean and her family that I hope you can see. So as you all know, we're bound together by this signaling pathway, the RAS pathway, and there are a lot of connections amongst the proteins or the genes within this pathway, as well as connections between the syndromes. The point of this slide is just to remind us that if we make progress on understanding the complicated cell network, then we hopefully can make progress on understanding the features that underlie these syndromes. One of our campaigns that we do is to raise money through the $1 Million Bike Ride. We had a successful bike ride this year where we were able to raise over $60,000 for a project, to fund a project, and we're currently reviewing those projects. This is just a few snapshots of the riders and the helpers. Next year will be the 10th anniversary, so if anyone's interested in participating in this to raise money for research, 100% of it will go toward a research project. In the past, we have funded we've funded 8 projects. I believe we're close to $400,000 on all sorts of topics and with researchers from around the world. So we want to keep this going. We want to push the envelope and try to understand our disorders and how to treat them much better in the future. Also, I just want to mention that we are developing the program for our symposium next summer, July 21 through 23 of 2023, which will be held in Denver, Colorado. And we are going to focus on global perspectives in research and practice, thinking ahead to the future, thinking about building cohorts and collaborations. So stay tuned, keep informed, and we'll post more about that in the future. Also, I just want to mention that we have a contact registry. If you're interested in providing your brief demographic and contact information, we can send you newsletters or research studies that you may find useful to participate in or that you want to participate in. And this is the information that we collect. I want to thank you for your attention, and I now want to introduce our speakers. We have Dagmar Tiemens. She has a master's in science and molecular biology and biology teaching, and she's currently a PhD candidate, in the Department of Pediatrics at Radboud University Medical Center. She's also a parent advocate, and together with her husband, they have a 14-year-old daughter, and so they've experienced this in their own family, and so she's an expert in both facets to be able to talk about it from personal experience and now from a research perspective. She works in the lab of Dr. Jos Draaisma, and he's with us as well today, pediatrician and principal lecturer, Department of Pediatrics at Radboud and Amelie Children's Hospital in the Netherlands. He specializes in Noonan syndrome spectrum disorders and has other areas of interest as well. So we're really pleased to have you here today, and I will let you take it away. I will stop screen sharing now. Stop share. All right. Dagmar, would you like to go ahead?
Yes, I will start with thank you, Beth, first of all, and then hello, everybody, and welcome. Thank you for joining us today on this webinar. I'm going to start to share my screen here and take it away with the presentation.
Looks good.
Thank you. So this is visible?
Yes, I can see that.
Okay. We are thankful for the opportunity to present our most recent research on feeding problems, particularly because we are part of the European Counseling team to update the current clinical management guidelines. We are eager to both learn and share recent insights on this particular topic. Before going to the next slide, I would like to ask everyone to postpone your questions and remarks until the Q&A part. Then also Dr. Draaisma can answer any of your questions. First, I will give an overview of feeding-related problems and tell about our personal experience, both in a personal and then a more scientific and objective manner. I also want to talk about the huge variation in complaints we see and dive into a possible explanation, focusing especially on the vomiting issues. Finally, I will give a short overview of our work on management of feeding problems, which we published in January of this year. So, feeding problems in RASopathies. I'm not sure if the bar is also in, you can read it a little bit. Okay. Feeding problems in RASopathies. At prenatal age, polyhydramnios during pregnancy is quite common in RASopathies and a potential red flag. In the first year of age, prolonged feeding times, insufficient daily intake, GERD, frequent vomiting, apparent lack of interest in food, problems maintaining a healthy weight, energy expenditure, metabolic rate issues, recurrent ear, nose, and throat infections, I will call that ENT from now on, and constipation also are seen in the clinic. From 1 year to 11 years, but also all through adulthood, some problems may keep on existing or appear for the first time. Problems can vary with aging. The transition from fluid food into solid food intake can bring additional problems like chewing, gagging, and swallowing problems, and avoidance of consistency or certain specific preferences. In combination with negative experience like ENT infections or vomiting, a child may learn to avoid food intake and refuses to eat at all. Eating and feeding may be a challenge in a normal, healthy infant, but when there is a RASopathy involved, this seems to add even more to this challenge. First, I would like to state that my daughter Lotte, her problems may be more severe and took much more time to overcome than the average RASopathy child, so I do not want to alarm anyone. On the other hand, this case does not stand on its own. Figures will show that 2/3 of children with a RASopathy experience feeding problems during a certain period of time, as we will discuss later. By sharing our personal experience and especially the medical milestones that have helped us, we hope to inspire others and hopefully may help make their journey a little more easy. The feeding problems with Lotte started with enlarged feeding times. It took more than an hour to finish a bottle. When she was 2 months old, tube feeding started. At the age of 3, ENT problems started. As we now know, pain in the ear, nose, and throat area may contribute to aversion of swallowing and eating, creating feeding problems. So looking to effective ENT management can be very important. Also, you may consider surgery to enlarge the inner ear tube to create an ear tube environment where infections have less chance to survive. You may want to ask the ENT physician a step-by-step plan for medical treatment if the ENT problems keep persisting. We also received such a plan from her dermatologist to manage her skin problems. Aside from the ENT infections, also the vomiting started at 3 months, which could be as much as 20 times per day. First, we lowered the portion size, then we switched to a hypoallergen food like Neocleat. When she was 6 months old, we lowered the pump speed to 50 milliliters per hour, and to ensure she got enough food, we had to feed her from 7 in the morning until 11 in the evening. Medical treatments like domperidone, alternating with erythromycin, we have tried for almost 4 years without any results. When she turned 1.5 years old, she started to move around on her buttocks, but was way too small to carry the pump around. So we put the pump in a rolling toy of one of her older brothers, so she could move around freely. We put when she was 2 years old, as most RASopathy children turn out to do, finally the vomiting frequencies dropped to around once a day, except when she got ENT problems. Then the frequency increased again. She got 3 years of therapy sessions by several speech therapists, 2 and later 1 time per week. The focus was on improving her feeding skills, playing and getting used to food. She enjoyed the lessons and we played and practiced at home, unfortunately with no increase in her oral food intake. She got a clinical diagnosis of not able to learn how to eat at the age of 4. So all therapy sessions stopped. Looking backwards, she just needed 3 more milestones to overcome her feeding problems. When she was 5, she received one specific medication that stopped her vomiting. This was ondansetron. And at the age of 6.5, we learned about a special eating school facility with multidisciplinary help called PsyCentra. There she got a new diagnosis called RFID and treatment by a behavioral therapist. Now, the focus of treatment by a behavioral therapist compared to a speech therapist is different. A speech therapist focuses more on developing feeding skills, a behavioral therapist on behavior and emotions. Lotte had learned that eating meant pain, vomiting, swallowing because of ENT infections. She slowly had to learn to connect eating with more pleasant feelings. So she got rewarded every time she showed a positive response to a small step in her eating process. First, accepting a drop of water, then a drop of vanilla dessert. This could only get accomplished by increasing the treatment frequency from 2 times per week to 20 times per week. For this purpose, she had to transfer from her normal school to the eating school. So she did for 9 months. During this time, she learned to eat everything. No restrictions, no preferences. Now, children do not need to be 6 or 7 to successfully overcome RFID. Also, children aged 2 or 3 were present at this eating school to overcome their avoidance behavior. What was striking, though, was the amount of calories our daughter needed. Because the facility measured her weight and also calculated the exact amount of calories of her intake, they concluded she needed a high caloric diet of around 1800 kilocalories. You may think of full milk, full fat, lots of porridge, lots of desserts, peanut butter on her sandwiches, and so on. She got 7 meals per day every day. So here you can see an overview of several measurements that are quite normal to collect. In the first column, there you can see her age from 0 to 12 years, then her length in relation with the average population. Then you can see her length drop under -2, getting seriously low, and even -4. As this is significantly smaller than the average population, at the age of 5, she started with growth hormone therapy, which she still receives today. Her weight stayed behind also, which is logical with a small length, but even her BMI stayed behind, which corrects for a short stature. This in contrast to her recommended daily intake that was calculated by a dietitian, and that was over 130% compared to other children of her age. She kept having problems maintaining a healthy weight, even with 7 large meals per day. At the age of 8, she got supplementary medical food. Although this did feel like a step back, it did the final trick, and since then she had no more feeding problems. Just to show the supplementary medical foods that are available, there is a high caloric liquid that we pour in her porridge in the morning and her dessert in the evening. During the day at school or at school care, she eats an additional 2 medical desserts without any problem, adding an additional 557 kilocalories to her normal diet. Do you suspect that you or your child need more food than average? You or your dietitian can calculate the daily intake and compare this to the average values. But there is an even more precise way to measure this. This is Lotte. She looks like she is asleep, but in fact she's watching YouTube on her phone. You can see it on the left, that sits on top of a plastic cap. The cap is connected to a computer that exactly measures the amount of oxygen she uses and the amount of carbon dioxide she breathes out. As was suspected, her resting energy expenditure was high, more than 1.5 times higher than other children of her age. So this confirmed her high metabolic rate. So does this one case stand on its own? Retrospective research of 108 children with the Noonan syndrome spectrum disorder showed that 29% of children aged 0 to 6 years old had an oral diet with restrictions, and 37% was dependent on tube feeding for some period of time. Together, it is 66% of children aged 0 to 6 years old. Looking at the genotypes, you can see it in the table, we see that P2P11 children were more affected than SOS1 children. Looking at the other genes altogether, feeding problems were even more significant, with 79% experiencing feeding problems, and even more than half of the children were dependent on tube feeding. Here you can see the same results, except that you can see now more genotypes that are shown separately. Now, does Dr. Draaisma research stand on its own? No, also other studies show similar results. One of them was executed in 2012. One of their results showed BMI scores per genotype. As BMI is correcting for length, it is a good measurement to compare. The vertical scale shows a BMI standard deviation score that shows how much an average measurement differs from the average population. This study relates even to the average Noonan syndrome population. You can see that the genotypes RAV1 and RAV showed a BMI above average, and CRAS and SHOC2 showed a BMI under average. Due to small numbers, other genotypes were not investigated. These findings were confirmed by a study in 2016, although these measurements did not contain SDS score. The average results showed similar outcomes. Da Silva and others speculated that the reduced BMI in CRAS and SHOC2 may be due to reduced muscle or adipose, that is fat tissue, in these children. So some of the genotypes seem to have a larger BMI, possibly due to a low or normal metabolic rate or energy expenditure, and this may protect them from developing weight problems when they experience feeding problems. The genotypes with a reduced BMI, on the other hand, may have a triple problem. When they experiencing feeding problems, food intake may not be enough. They may lose food by vomiting, and also seem to need more food than average to maintain a healthy weight. This may seriously lead to malnutrition and growth problems. Now, how come that there is also a group of RASopathy patients that do not experience feeding problems? How come there is so much variation among RASopathy patients? At the website of the RASopathies network, there is an excellent film you probably all know, explaining what RASopathies are and what goes wrong in cellular communication when there is a sick-making or pathogenic mutation in one of its components, causing the genetic disease. When we try to figure out how the variation between individuals with any genetic blueprint, including those with a genetic condition, occur, even relatives of the same family, we have to dive into the mechanisms that are responsible for creating our individual characteristics. We are made up of trillions of cells. There are around 200 different cell types that may look very different and have a specialized function, like a smooth muscle cell does not resemble a neuron cell at all. There are also similarities. Each cell contains the same DNA with the same genetic code containing around 20,000 genes that create around 20,000 proteins or building blocks responsible for the cell's traits and characteristics. The DNA is stored in a separate compartment inside the cell called the nucleus. Each cell is surrounded by a tiny membrane that, like a raincoat, protects every cell from its surroundings. There are tiny holes guarded by portals that allow some signals to enter the cells and give cells clear information on how to properly react on events happening outside. Those signals are being transferred along a so-called cellular information highway that are fast and reliable and look the same in every cell type. One example of such an information highway is the RAS-MAP kinase pathway. So how come cells with the exact same DNA can look so different? Because not every gene that can create a building block or a protein or trait is switched on in every cell. When a fertilized egg divides and keeps on dividing into an organism with trillions of cells, in every cell type, some genes get switched permanently on and other genes get switched permanently off, and additionally passes this switch on when the cell keeps on going, dividing into more cells. So although in every cell type there is the same DNA present, not all proteins are equally produced, so are not equally present in each cell type. As DNA also differs in every person a little bit, even in identical twins, the set of the 20,000 proteins that can be produced also differs in every individual. So while in every cell type, as far as we know, the RAS-MAP kinase information pathway is present, it interacts with a unique set of proteins in each individual. Also, relatives that have the exact same pathogenic mutation have their unique set of proteins the pathogenic mutation, a mutated component interacts with, giving each individual its unique set of traits, and in the case of a RASopathy, unfortunately, its unique set of challenges or problems. The RAS-MAP kinase pathway consists of RAS, RAF, MAC, and ERK. The main target of the pathway is ERK. Once ERK is being activated, it aims for specific targets like genes or proteins or other cellular substrates that can differ per cell, as each cell type has its specific set of proteins. So ERK will aim at different or may aim at different targets in a neuron cell than it could aim for in a smooth muscle cell. Now, we know that the RAS-MAP kinase information highway is composed of a lot more components that over the years seem to be essential to help shape and regulate it. Research has shown that a pathogenic mutation in almost every single component results in a specific RASopathy. The light green bubbles form the core of the pathway: RAS, RAF, MAC, and ERK. Most of the darker green components are essential adapter or regulatory components of the pathway. Under to the left, you can see which genes belong to which clinical diagnosis. The red bubbles show the components that result in an NF-related syndrome. And finally, in the yellow bubbles, you can see the activated ERK, called PERK, aiming for specific targets. Dysregulated ERK often results in ERK hyperactivation, meaning that the targets of ERK may be hyperactivated or produced in larger amounts than would be without the RASopathy. So what does that mean in relation to feeding problems or, for example, in vomiting? Here you see a schematic drawing of a nerve cell in the brainstem of an animal model. After applying a vomiting-inducing agent, indicated by the stingy red balloon at the top of the picture, in several steps, you can see ERK here activated, releasing substance P here. An increase in substance P eventually evokes emesis, and emesis is another word for vomiting. So this animal starts to vomit after applying this drug. In RASopathies, of course, there is not a vomiting-inducing drug present, but there is hyperactivation or overproduction of ARK. To the right, you see the RAS kinase pathway with hyperactivation of its components shown by the orange arrows on the right. Overly active ERK in nerve cells of the brainstem may overly produce substance P. Overactivation, more substance P, similar to the vomiting-inducing drugs. This is what we hypothesize. Additionally, in RASopathies, feeding problems can be caused by delayed gastric emptying. What does delayed gastric emptying mean? It means that the bowel movement in the stomach is not forceful or too slow, so food stays in too long. In gastric bowel movements, several kinds of nerve cells and smooth muscle cells are involved. Every nerve and every smooth muscle cell carries its own and unique set of proteins, and each has its own ERK targets. Dysregulated ERK targets in nerve cells or in contractile elements of the smooth muscle cells may prevent or slow down smooth muscle contraction. This may leave the stomach full, which can affect feelings of hunger or stimulate the flow of food back to the esophagus or the mouth, resulting in reflux, GERD, or vomiting. So in conclusion, vomiting may be induced by several mechanisms at separate locations, like the brain, the stomach, or the peripheral nervous system. As if this is not complex enough, the organs and tissues that are involved in feeding problems extend even beyond the tissues we have mentioned so far. The mouth that is responsible for chewing and swallowing contains striated muscle tissue. We also have not yet mentioned the nose or the larynx that can be involved in hyper or decreased sensitivity. Also, there are fiber type cells, mucus cells, and so on. All can be involved and, more importantly, may be targets for specific medication. For instance, why does ondansetron seem to be so effective in many RASopathy patients suffering from vomiting? So now we have come to the part on how to manage feeding problems clinically. To simplify things, we have split feeding problems up in 4 subdomains with its own professional specialists. Looking at feeding problems, you can identify medical, nutritional, feeding skills, and psychosocial dysfunction. Medical dysfunction can be managed by a pediatrician, handling several issues, for instance, finding effective medical treatment of the GERD or vomiting. But management may require a multidisciplinary approach, which may consist of a dietitian, an ENT specialist, a surgeon, a neurologist, or even a dermatologist. To manage nutritional dysfunction, it is important to measure growth parameters like weight, length, but also the size of the head every 3 months. The head or the skull may be relatively large and may mask a low weight in the rest of the body. A dietitian can assess and manage caloric requirements and possible high energy expenditure. Nutritional dysfunction can lead to malnutrition or nutrition deficiency and may require formula supplementation, nutritional supplements, and enteral tube feeding. Feeding skill dysfunction often requires a speech-language therapist who can offer technical feeding therapy to overcome underdeveloped feeding skills. A need for texture modifications, the use of modified feeding position, of the use of the modified feeding strategies. Also, a speech therapist can help to desensitize or oral hypersensitivity like gagging and overcome weak suck or eating techniques. When there is no improvement in the food intake volume, psychosocial dysfunction can be evaluated. The child may have developed RFID. Cognitive behavioral therapy may be necessary to overcome persistent feeding avoidance strategies. It may be important to analyze and support the parent-child interaction that may or may not be distorted within the context of feeding problems. Complex RFID may require multidisciplinary care and outpatient day treatment with multiple sessions a day for longer periods of time. As children with a RASopathy may have a higher than normal energy expenditure, treatment with hunger provocation strategy could be contraindicated. So this is the last slide. To sum it all up, feeding problems are frequent among children with a RASopathy. Children with a rare genetic variant even have a higher risk. Feeding problems are complex. The problems may vary and also the causes may differ due to individual variations. Most often, feeding problems ask for multidisciplinary evaluation and management. Thank you all, also on behalf of Lotte. And are there any questions?
Thank you so much for that presentation. That was really informative. I especially liked how you brought in the background biology as well. That's, I think, something that we didn't know a lot about and was really helpful. Before we open it up completely, I would like to just give one of our participants a few minutes to speak about her situation. Her name is Katie Palmer, and she is an adult with a RASopathy, and she is a self-advocate as well. You may have seen her on the Facebook pages, but I'm going to let her speak for just a few minutes, and then we will open it up completely. Katie, are you there?
Yeah, I'm here.
Great, welcome.
Thank you. So I'm Katie. I have the shock 2 gene of Noonan syndrome, and feeding difficulties is a huge problem for me. And it started back when I was a baby, and it was just about vomiting. I just wouldn't tolerate anything. So then it persisted through childhood, right up to adulthood, and it's still the same today. It's much better today. Over a year ago now, I did start tolerating normal foods, which has been an excellent experience. But it still is a little bit complex. So yeah, I'm fed via a gastrostomy, a G-tube, and that's within about 3 hours within the night. So yeah.
Great. Well, thank you for sharing. You know, I think it also learning a little bit more about the biology allows maybe the parents to maybe not blame themselves so much that it's something that they're doing wrong. You know, I think that's important. So
as well that I don't have the learning difficulty side of Noonan syndrome. I think that a lot of people throughout childhood thought it was down to behavior, which it totally was not.
Yeah.
So
all right. I want to thank everybody for sharing and participating today. I think it was a really informative discussion, and if people feel like it's something that they would like to continue the conversation on, please let us know. You can email us at info@rasopathiesnet.org. We can pass questions on to Dr. Draaisma or to Dagmar, and or you know, set up another sharing webinar and just give us some feedback. We like to hear from you, and we hope that you found this to be useful and informative. I want to thank our speakers today. Thank you so much for sharing and for all the work you're doing, Dagmar Tiemens and Dr. Draaisma as well. And Katie, thank you for letting us know about your story.
Thank you also, Liza and Beth, and I hope we have contributed to a little more knowledge and support on the feeding problems journey.
Have a great day or rest of your evening, everyone, and stay tuned for the next in our series of webinars. Feel free to tell us if you have any other subjects that you'd like to hear about.
Yes.
Thank you.
Sorry about that. Okay, bye for now.